Thank you. Welcome, everyone. I'm Susan Lapidus, Director of the Murray Gallatin San Diego Israel Initiative, MGSDII for short. Our mission is to bring Israel studies to San Diego universities in our community, as well as building collaborations and relationships between students and professors in San Diego and Israel. We are proud to bring you this discussion about loneliness and the elderly during the COVID-19 pandemic. Special welcome to the students and professors on this call, as well as our community partners. Our speakers today are world-renowned experts on aging from Israel and San Diego. Funded by MGSDII, they have been collaborating for the last year and have visited each other's universities in San Diego and Haifa. Together, they will discuss solutions and the recently funded collaboration to help vulnerable elderly populations, including Holocaust survivors in both San Diego and Israel. The second part of the collaboration will happen next academic year when an expert from University of Haifa will be visiting UC San Diego to teach. Before I introduce our speakers, a little housekeeping. We expect over 200 people on this webinar. Each of our speakers will do presentations, and then we will take questions from the audience that you could post via the Q&A feature. We will also be taping this, and it will be posted on our website later today. I'm honored to introduce our panelists. Issi Doron is the head of the Center for Research and Study of Aging at the University of Haifa. He is Israel's foremost expert on aging and is known worldwide as the field's international academic expert. He has written extensively on topics such as innovations on aging and human rights of older persons. He will be joined by his colleague from University of Haifa, Michael Isaacson. Dilip Jeste is the director of the Stein Institute for Research on Aging at UC San Diego. He completed his psychiatry residency at Cornell. He started the geriatric psychiatry program from scratch at UC San Diego. Today, it is one of the largest geriatric psychiatry divisions in the world. He will be joined by Danielle Glorioso, the executive director of their institute. Issi, I believe you are speaking first.
Thank you. Thank you so much. It's an honor and a pleasure for me to be here today. I will be using a PowerPoint, so I will just share it on the screen so you can all see it. Susan, if you can just let me know that you can all actually see the presentation.
I see it.
Is that okay?
It's good.
Okay, excellent. Good. So first of all, I would like to say a few words of thanks. I would like to really, truly thank Susan Lapidus and the Murray Gallatin San Diego Israel Initiative, MGSDII. I cannot say enough on the kind hospitality I had 2 years ago visiting San Diego and the excellent initiative to promote collaboration between University of Haifa and Israel and San Diego. It's a wonderful initiative, and Susan, thank you so much for your excellent work. I would like to also thank Professor Jeste and the Stein Institute for Research on Aging at UCSD. Once again, an outstanding scholar and an outstanding institution, and it's an honor for us here in Israel at the University of Haifa to collaborate and to work together. And finally, thank you all people who are joining us now. Regards from Israel. It's night here at Israel, but we are with you in our hearts, and it's a pleasure to have you. And thank you so much for joining us. In this very short presentation, I will basically try to do 3 things. First, to give you a very broad background about the aging in Israel and our experience of the COVID-19. Second, I would like to try to give you a few insights regarding loneliness and old age in general in the context of the COVID-19. And finally, to have a short conclusion with some general insights about this crisis and what's going on. So let me dive directly into my presentation. I assume that most of you know that Israel is a very small country, both geographically and demographically. We have around a little bit more than 9 million people all together. The vast majority is Jewish. However, we have a significant minority of Arabs and non-Jews, as you can see. Generally speaking, we have around 12% of our population is what we call old, above the age of 65, which is lower than the US, which is about 16% to the best of my knowledge. So it's somewhere in the middle. We don't have as high as aging population in other developed countries, but certainly more than developing countries. In Israel, we have quite a high life expectancy, higher than the US actually. So the average life expectancy at birth is around 85 for women and 81 for men. So the reason we don't have as high a rate of older people compared to other countries percentage-wise is our fertility rate. We have almost the highest fertility rate in OECD countries, 3.1 children per woman. And as you know, many of our religious parts and Arab parts have quite a high fertility rate. So overall, the picture, I would say, as you can see in this picture on your right, and I apologize about the fact that the headings are in Hebrew, is that if you see from the 1960s and looking forward to 2030, like many Western countries, Israel is experiencing an aging phenomena. But as you can see, specifically in the 10, 20 years, we're going to have a significant increase in our aging population. So let's move to the situation of COVID-19 in Israel. As of this morning, overall, totally speaking, we have 61,000 or 62,000 people who have been infected by the COVID-19. Out of them, 34,000 are still ill. As of today, 97 are under ventilators or connected to ventilator in serious condition. Totally, we have so far 470 people who have died out of COVID-19. And totally, we have around 15 or 16,000 examinations per day to testing people to whether they are ill. Looking in the last 4 or 5 months, we can see very clearly from this graph the first wave of our COVID-19. So in early March, we almost didn't have any new patients with the COVID-19. You can see the significant rise in the first wave of April. Then we have the significant closure and quite harsh steps, basically shutting down the country and the decline of the first wave. But you can see what we are now experiencing in Israel in the last few weeks, what we call the second wave, and a significant increase up to 2,000 new patients a day in the last 2 weeks, something that is really significant and worrisome. And we hope in the last few days that we're starting to see the decline, hopefully. Some general observation about the experience of COVID-19 in Israel from 2 perspectives. On the right, you can see the gender and age distributions with regard to people who are ill, who have been infected. Again, apologize for the Hebrew. As you can see, the vast majority of people who got ill and infected are young people in their 20s, and actually very small minority and percentage of older people who have become ill. However, on the left side, you see the number of deaths, people who actually died, and you see the total opposite. So you see that the majority of people who actually died from COVID-19, again, this is not unique to Israel, are people in their 80s and late 80s. So certainly the COVID-19 is an illness and pandemic about older people when we are relating to risk factors as such. So to conclude this part, when you compare Israel and the US, it's interesting to show that when you talk about numbers, you cannot compare numbers. In the US, you have more than almost 150 people who have died, and in Israel, you have only 470 people who died. However, when you compare it per million, so not only numbers, you can see that Israel has been much more successful, or the death rate in Israel is much lower, 41 people per million compared to 456 people in the US. So again, from this very limited data, at least on our the way we handled the first wave, I could say that Israel has done a little bit better than the US. So this is only a very broad introduction to give some sense about what's happening in Israel with regard to COVID-19, generally speaking, but now more specifically to the issue of loneliness. I'm sure that Professor Jeste will elaborate more, but generally speaking, anyone in the field of gerontology knows that loneliness is actually quite a complicated and complex concept, because there is a difference between being alone or socially isolated, which is a more an objective term, than feeling lonely, which is a more subjective term, which is sometimes chronic for a long time or only limited, very situational. And sometimes it has emotional and sometimes it has social aspects. And finally, one can also assume that sometimes there are actually positive elements to loneliness. So loneliness is not necessarily always negative. Now, we do know that from at least in Israeli data, loneliness is related to age. So as we can see on the right side, people who are older, the rate of people who are at least reporting subjectively that they are feeling lonely gets higher. The prevalence differs. There are different data in Israel because of the subjectivity and how you measure it. But as you can see, at least from what is known the share data, you have around 28% at the 65 and 74, and almost 50% at the age of 85 and higher of people who report subjectively of feeling lonely. Now, this is of course very important from a policy perspective, because as you can see over here, while you don't understand, in Hebrew it says that, as you can see, with regard to depression, there is a very high rate of depression within those who report of feeling subjectively lonely. So this is certainly a key issue and a social policy issue. If we do care about rights of older persons and of older persons, we do have to care about loneliness as a social phenomenon. Now, from this very general and broad perspective, trickling down to the COVID-19, we were fortunate in Israel to have a national survey about 2 months ago, which had a questionnaire asking older people about their experience in COVID-19. And the interesting finding, as you see on the right, this is a graph which shows the feelings and experiences of older persons during the COVID-19. So 15.2 is those who didn't report any emotional difficulty. But as you can see, 85%, all of these 85% of elderly people reported emotional difficulties. 60.5% reported that their main difficulty was the difficulty relating to the disconnect from their family members. And another interesting data is that 10.4% of older people said that in this kind of condition, meaning enclosure, they have no meaning for their life, which is quite a strong message. Now, beyond these data about the general emotional feelings, certainly we had many experiences relating to loneliness and infringements of human rights. So we found many cases in Israel of older people dying alone without any family members in hospitals and institutions, older people living for months alone without any connection with their family member in nursing homes and institutions. In the community, people who had some kind of informal network, again, isolated, reporting of difficulties, loneliness and despair, and other kinds of discrimination in other aspects, which I will not touch upon. Now, interesting enough, the findings of the survey in Israel found some interesting findings. For example, one fascinating finding was that comparing this current study to a different study that was held in 2018. So this one is the 2018 on the left, and on the right is the COVID-19. this is depression, and this is loneliness. As you can see, surprisingly, there was no real significant difference in the reporting of feeling of loneliness and feeling of depression, comparing the COVID-19 time and the 2018. So actually there was a good sign that older people are actually more resilient and are mentally stronger than we might feel. Another interesting finding is what we call technology take-up. Again, in Hebrew, the green arrow shows the increase of use in new technology, increase of time they talk with family members, increase in things they do as a leisure, which they are interesting, and increasing reading books. So we definitely saw an interesting phenomena of older people taking up initiatives and activities to struggle or to tackle their loneliness or their isolation while using technology. And finally, a very interesting issue was appearances of social activism. So we saw a whole wave of letters to the editor, a whole wave of older people who are unwilling to accept the social construction of older people as weak and able. So generally speaking, I think, again, in this very short presentation, if I would like to have some insights before moving the floor to Professor Jeste, I think that one insight is the relevance and significance of family members and informal support networks in crises like the COVID-19 and pandemics, and the importance and significance of these elements to allow people to overcome loneliness. Certainly, I think the issue of institutions and long-term care institution has been a significant issue, and there are many calls to minimize or even to end nursing homes as we know right now in Israel. I think there are certainly calls about the significance of technology, and we will talk about it later on about the collaboration between San Diego and Israel. And finally, the issue about when we talk about older people, are we talking about them and without them? Or should we shift the paradigm and see how we can include and have older people as part of the decision making? This final graph or figure shows again the findings of our survey, and the bottom line is, as it says here, that despite the isolation and despite the mandated disconnect between older people and their families, family and informal network was a critical factor to alleviate and to prevent depression and loneliness in older population in Israel. So I will stop here at this stage. And once again, thank you very much for listening. And I hope that I can be able to answer questions later. Thank you very much. Professor Jeste, will you take the floor?
Yes, Moni.
Thank you very much.
What we want to start with is how exciting this unique collaboration is. So as I mentioned, we've launched a multi-site innovative collaboration between UC San Diego Center for Healthy Aging and the University of Haifa, Israel, with the goal of addressing the worldwide issue of loneliness and social isolation among older adults during the COVID-19 pandemic. So this innovative program aims to address the issues of COVID-19 loneliness through this unique collaboration, which is going to be in two different formats. Hold on, I gotta just. Okay. So the funding provides two different tracks for us. The first part is a research piece, and the second part, it funds a visiting scholar. So the research funding will allow us to tailor and develop a unique intervention that will reduce loneliness, that seeks to reduce loneliness in older adults. So this project is near and dear to my heart. As some of you may know, the Center for Healthy Aging has been working to develop interventions to reduce loneliness for several years now. And this new funding will allow us to adapt this intervention that we developed real time to address the issue of loneliness. So part of the work that we've been doing over the last few months is working with our collaborators at University of Haifa to make this manual ready to go. We'll use technology-assisted intervention to address, to enhance compassion and empathy in order to reduce loneliness and prevent and promote well-being. The second piece of the funding will fund a visiting scholar from University of Haifa to come to University of California, San Diego in the academic year of 2021-2022 to do some teaching and some research. So we're really looking forward to learning from this intervention and being able to use that in the coming academic year. So the project that we are developing now is a 6-week intervention. It will be conducted twice a week, and it will be 30-minute sessions, and these will be done by trained facilitators. So these will be individual sessions, one-on-one, and they will be conducted either by telephone or by some video-based web platform like Zoom, and Michal will mention a few other options as well. The goal here really is to try to connect with as many older adults as possible. And we don't want to have to exclude older adults because they don't have access to computers or Wi-Fi. So we are allowing older adults to do this by phone as well. In order to determine if this intervention is effective, we're going to be conducting assessments at 3 different time points. We'll be doing a battery of assessments before they start the intervention, which is baseline. We'll be doing another battery of assessments at the end of the intervention, which is 6 weeks. And then we'll be doing a 6-week post-intervention at 12-week just to see if any of the benefits that they develop during the intervention stand. A couple of components of this intervention. We will be looking at different strategies to address cognitive, affective, and behavioral components of loneliness, like education about empathy and compassion, helping them develop self-compassionate exercises. They'll be instructed to complete a daily gratitude journal. They'll be developing role plays and mindfulness exercises. And we'll also be asking them to engage in activities such as savoring things, learning to engage in gratitude on a regular basis, and making sure that they develop goals associated with things that matter to them. So we are currently developing the manual and will begin recruitment shortly for this multi-site study. So there'll be a total of 60 older adults. 30 of them will be in the United States and 30 of them will be in Israel. And as Susan mentioned, we'll be making special attention to recruit a subset of Holocaust survivors. We're in the phase of finalizing the manual and getting everything ready to launch. So we're hoping that within the coming weeks, we will be able to get recruitment started for this intervention. And now I have Michal's slide.
Okay. Hi, everyone. So I'm happy to talk about 2 aspects of our project. The first aspect is using technology, and that's one of the ways that this intervention is especially interesting and exciting. One of the things that we know about technology, and if I connect to what Professor Jeste was talking about earlier, is we know that technology seems to be very useful in engaging loneliness and broadening social connections. But we also know that many people that use technology are actually very lonely. One of the things that we know is that younger people, younger cohorts are actually the loneliest people, the loneliest cohorts that we're aware of. So using technology can create loneliness and not only elevate loneliness. Another one of the things that we're interested in learning is how we're able to connect and create a sense of connection over technology among older adults among people who didn't use technology like this when they were younger, and technology is new for them, at least relatively new from the past few years. So this isn't an experience that they had when they were children or younger adults. An aspect that we actually put aside in this project is the aspect of technology adoption. And as Danielle said, we're not going to be looking at who's able to adopt technology and who isn't. And we're going to be giving different options for participants to participate and not make technology an obstacle for participation. Danielle, could I have my next slide? Okay. And another aspect that we're very excited about is being able to compare two different subsets and two different samples in very different locations. And I just want to talk for a few minutes about the differences and what we expect to learn and why we're so excited about this opportunity to compare people living in San Diego and people living in Israel in the Haifa area. For many times when you do studies like this, you're not able to compare your findings, and you never know if they're very specific to the location and to the culture that you're working in. And being able to make this cross-cultural connection and comparison will richen our results. That said, some of the differences that are highly connected to loneliness, as Issi showed in his presentation, are familial structure of families, and expectations of connection with families between people living in the United States and people living in Israel. And as Issi showed earlier, Israel is a warm Mediterranean culture and country, and it's actually we rank very high in loneliness in European surveys and international surveys, which people find to be surprising at the beginning, thinking that people are well connected and not understanding why people are so lonely here in Israel. But if we consider what Professor Jeste was presenting earlier, and we think about what loneliness actually is, if loneliness actually is the discrepancy or the difference between our expectation for connection and the way we perceive our connections, we can understand how actually in a warm country, in a country that is perceived to have very close social connections, people can be very lonely, because people have very high expectations of their families and of society to be close with them, and the actual realization of those connections may seem lacking to many people and may leave them feeling lonely. Family structures in the United States are very different. People usually live at, people in Israel tend to meet probably on a weekly basis or very frequently with their children and grandchildren, while in the United States, people live at larger distances, and that's not as common as you'd find it in Israel. So that will be one interesting aspect. And another very interesting aspect, as Danielle mentioned, we have this subsample of Holocaust survivors, which will be wonderful for us to be able to look at these two different distinct societies and locations where people are living, and looking at the same cohorts, the same at people that begun their lives in similar circumstances, but ended up living their lives in different locations, how each of those participants and each of those older adults reacts in similar and different ways to the intervention that we're proposing. That's it. Thank you.
Wonderful. We'll switch back to Dilip to see if he's able to run his presentation again. And if not, we will pivot a little bit and answer some questions. Dilip, are you hear us?
Can you hear me?
Yep, perfectly.
Great. So maybe you can show my slide. I will appreciate that.
Yep. 1 second. Let me pull up and share my screen. And then you'll just need to let me know when to advance the slides.
Sure. Okay. So you can start the first one. I will. Okay. Thank you. So again, sorry for all this technological problem.
No, you're totally fine.
Okay. So I was talking about the similarities and difference between loneliness and social isolation. Loneliness is subjective, social isolation is objective. Next slide, please. So there's a modern pandemic of loneliness. When we talk about pandemic, we think about COVID, and COVID-19 is of course a pandemic that has been going on for the last 7 months that has killed so many people. But the pandemic of loneliness has been going on for the last 2 to 3 decades. And in the US alone, 160,000 people per year are dying from illnesses related to loneliness, such as opioid abuse, suicides, as well as several physical illnesses. Next slide, please. Loneliness has been shown to increase the risk for heart disease, diabetes, obesity, major depression with suicide, opioid and alcohol use, generalized anxiety disorder and other anxiety disorders, and Alzheimer's disease, as well as other dementia. So loneliness is a serious problem that increases the risk of these diseases, which are obviously themselves major killers of the population. Next one, please. What are the risk factors for loneliness, or who are the people who are more likely to be lonely? In terms of age, it is interesting that loneliness can occur at all ages. And in our study, we found that it was particularly common in 20s, 50s, and 80s. All of these are periods of stresses of different kinds, and they lead to increased loneliness. People with physical illnesses are more likely to be lonely. Similarly, people who have chronic work stress or social stress, people who are socioeconomically disadvantaged, ethnic minorities, people who are poor, or people with lower levels of education are all at high risk of loneliness. Small social network. And even more important is the quality of social relationship. So even if you have many friends, if the quality of the relationship is not good, one would be lonely. And finally, being single or having stressful marital relationship is also a major risk factor. So in other ways, that the protective factors against loneliness include a good quality social relationship, being married, and having been relatively free of physical illnesses. Next slide, please. The good news is that there is an possible antidote for loneliness. I talked about the behavioral pandemic of loneliness. So there is possibly a behavioral vaccine for that, and that is wisdom. I will talk about what wisdom is in the next couple of slides, but I want to show you this study that we did in San Diego. It included more than 200 people. And what you see is the relationship of loneliness and wisdom. So you will see on the lower part, especially on the right half, there are lots of people. So these are people who have high levels of wisdom and low levels of loneliness. Next one, please. So what is wisdom? Wisdom is much more than intelligence. Wisdom is a complex, multi-component personality trait that involves several specific components. I will show you those components in the next slide. Let's go back to the previous slide. Intelligence does not increase with age, but wisdom often tends to increase with age. Specifically, some components of wisdom have been shown to be significantly higher in older people than in younger people. The people who are intelligent are not necessarily happy. Also, they are not necessarily contributing to the society's welfare, whereas wisdom is associated with personal well-being as well as the society's welfare. That's why wisdom is much more than intelligence and is much more important for that reason. Next slide, please. So what does wisdom include? As I said, it includes specific components. Which components? Next one, please. You can click on the, yes. The first component is self-reflection. It is ability to look inward, ability to understand ourselves. Why did I go wrong? What should I do better? Rather than blaming somebody else. So that is self-reflection. Next one is compassion or kindness. Compassion towards others, but also compassion towards ourselves. Self-compassion is important. Next one, emotional regulation, control over one's emotions. Think about a teenager, how his emotions fluctuate from hour to hour and minute to minute. And think about a wise older person who has very good control over the emotions. Next one, please. Then comes decisiveness amid uncertainty. So on the one hand, a wise person accepts uncertainties in life and accepts that there are different perspectives that different people have, and they all may be okay. At the same time, she or he cannot sit on the fence. The wise person is also decisive when it is needed. And then finally, next one, please. Spirituality. Spirituality is different from religiosity. And spirituality means connectedness to something that is beyond what we see or know or hear. So that way, you're always connected with somebody. Next slide, please. So as I said, we are in the midst of two pandemics, the COVID-19, and right now, that is why we are spending billions of dollars appropriately for developing antivirus agents as well as vaccine. But how do we develop a vaccine for a chronic behavioral pandemic like loneliness that has been killing thousands of people for the last 20 to 30 years? So we need wisdom, both individual level wisdom intervention and societal level intervention. Can we really increase wisdom? Next slide, please. We very recently published a study, and Danielle was actively involved in that study. This is a 1-month behavioral intervention, and it was administered not by an MD or PhD or trained researcher, but by unlicensed residential staff in senior housing communities or retirement communities. We chose 5 such communities in California, Arizona, and Illinois. And the intervention included savoring, enjoying the things that you do while you like, engaging in value-based activities, activities that you really feel are important, keeping a gratitude diary in which you express your appreciation for others' help, and doing these things on a daily basis as a part of your homework. We found, and this was a randomized controlled trial, we found that after 1 month of this intervention, there was significant improvement in wisdom, resilience, and the subjective stress went down. We looked at loneliness in a small subsection, and we found that loneliness also decreased in that study. So this shows that you can increase wisdom and reduce loneliness, at least in some people with a behavioral intervention. Next slide, please. Now we need to think about societal level. So why is the loneliness going on for the last 20 to 30 years? Part of it is increased globalization, as well as incredibly rapid advances in technology. Although as we saw in my talk, the technology sometimes fails, right? The Zoom doesn't work, and then we have to still fight with it. Nonetheless, this globalization and technology have been helpful in many ways. On the other hand, they are upending long-held social mores, and they're causing modern behavioral pandemics of loneliness, opioid abuse, and suicide. What has happened is the stress level has markedly increased in the last 20 to 30 years in all age groups, starting with younger people and going on to the older people. And as you saw, we found that wisdom goes in the opposite direction as loneliness. And if you increase wisdom, loneliness can go down. So we need to try and see how we can increase wisdom, not only at individual level, but even at societal level. How can we increase compassion, self-reflection, emotional regulation, accepting diversity, and spirituality? This is the kind of training we need to start from elementary school level, going on to high school and the various jobs we do. Next slide, please. And I want to give you just one example of how we can increase wisdom even at individual level. So the two components that are important are compassion and self-compassion. So what can we do? So in terms of compassion training, what we do, and this will be, by the way, a part of the links intervention that Danielle and Michal described, and that we will be trying thanks to the Mary Killinson Foundation support. So the compassion involves random acts of kindness to others. Just make it a practice that every day we do some random acts of kindness. And at the same time, we have to be self-compassionate. I have found that people are compassionate to others, but they're very harsh on themselves, self-punitive. That doesn't help. So be as kind to yourself as you are to others. And the common elements in both compassion and self-compassion are mindfulness, accepting the emotions, and sense of common humanity. When you make a mistake or somebody else makes a mistake, we should know that everybody makes mistake. It's not the end of the world. We can correct them. Next slide, please. One of my heroes is Viktor Frankl, one of the greatest philosophers in the world, Holocaust survivor, and his book, Man's Search for Meaning. And he said, those who have a why to live can bear almost any how. And in a way, that's the example of what Professor Doron was telling about, that these are older people, and yet they are not getting more depressed just because of the COVID, because they have a meaning, they have a purpose. And that purpose is something that one needs to define for oneself. And with age, as we become older, as I said, components of wisdom increase, and the wiser people develop a purpose for themselves. And then they won't be depressed. They will be more resilient, more wise. And my next slide is the last slide. Next one, yes. So if we can practice this, then today's society is largely lonely and distressed with high rates of suicide, opioid abuse. Let us change that and make it a healthier, happier, and wiser society. And that can be done if we can make wisdom a part of our everyday life. Let me stop here and thank you all for your attention.
Thanks, Dilip. So happy we were able to get you back on online. We were able to perfectly hear you. Susan?
Yes, thank you, everyone. And I didn't introduce Mitchell Price, who's the program director of the MGSDII. So Mitch, thank you for all your help. I've been monitoring the questions, and the one that's coming up most often is how do they participate in the study that you're starting? And some have asked for themselves, their parents, their partner. So who wants to jump in on that? Michal or Danielle?
Hi, Susan. That's a great question. And we're working on the details right now. But what I would say is, if they're interested and want to learn more about it, we'll be screening folks in the next few weeks. So they can contact us at, they can go to our website at aging.ucsd.edu. And I can field the folks that are local to the San Diego site. And I don't know about you, Michal, how you'd like to handle that.
Well, most of the people asking are from San Diego.
All from San Diego. Okay, perfect. Yeah.
So to the audience, we will be sending a follow-up email with Danielle's contact. Dilip, go ahead.
Yes, one thing I wanted to add is that, so this is a pilot study that has been funded. And so we will have about 30 people in San Diego, 30 in Haifa. But we want to do a larger study. We definitely do. But so what we plan to do, it will be to do this study and then get the results, and we fully expect that the results will be very helpful. And then we will apply for larger grants and larger funding. And in that case, we will actually have a much larger study than we have now. So if everybody doesn't get to participate in the study immediately, please hold on. We will expand the study before too long.
Dilip, another question from our audience is if you think our country, the States, should have a czar of loneliness on the national level or on the state level, and how would that work? How would you say it would best work?
I think we need to tackle loneliness at every level. I mean, it will be at the national level, state level, local community level, and individual level. I think people are now beginning to understand the importance of that. So the National Academy of Medicine and Sciences recently published a report that we need to assess loneliness in every single person. And so this is something physicians and other clinicians need to do. And then this intervention, really, I'm so happy that the Mary Gillenson initiative is supporting that, because those are the kinds of interventions that we need and expand.
Issi, do you have anything you want to add?
First of all, again, it was a fascinating point for me to hear both Dilip's presentation and Michal and Danielle. I think everyone who's listened to this presentation realized how fascinating and how we're excited about the coming collaboration and research. Personally, I'm coming from a macro societal level, so from a human rights perspective, my approach was always that we can change reality via instruments of changing how a society constructs old age and views older people. And if we can shift our societal attitudes and the position of older persons in society, eventually will also change the reality of loneliness for older people as well. So I totally agree with Dilip's description that we need to tackle loneliness in all levels of society and cannot limit ourselves to only one single level of approach.
Thank you. Here's another question. Someone was asking about elderly people who have personality disorders yielding very low levels of compassion and insight throughout their lives, and even have been diagnosed with dementia during COVID. Is there any, do they have any ability to gain wisdom so that they have a greater level of happiness?
My feeling is yes, actually, everybody has an opportunity to increase their level of wisdom. Now, wisdom, as I said, has different components, and all of us actually may be stronger in some components, but not in others. So the question is which component somebody needs help with. And those are the interventions actually we are working right now on each component and how to enhance that. But to answer the question, yes, actually it would be possible to increase the level of wisdom in a person, including people with dementia. Of course, that would involve not just the person with dementia, but all the caregivers also.
Great. Let me see. An audience member, Nancy Garcia, said there's probably more recognition of the effects of loneliness now more than ever. Maybe now it can also be seen as a public health crisis for all ages and a public health crisis for the elderly. Anyone want to comment about that?
So I understand. So that the question is that, in the sense, the thinking is that loneliness has been there all along, and now we are becoming more aware. That may or may not be true, though, because studies have shown that the levels of loneliness and stress actually have increased in the last 30 years. The rates of suicide have increased 30%. The rates of opioid-related deaths have increased 8-fold in the last 30 years. So I really think this is a modern pandemic caused by globalization and technology advances and other things. Issi may have other thoughts too.
Well, from my understanding of this question, and maybe Michal has other thoughts as well, from a perspective of being careful not to fall into the trap of ageism, and despite the data that both Dilip and I have presented, not only older people experience loneliness, especially in times like pandemics and COVID-19. Second of all, once you realize loneliness is not only an issue of older people, and you realize the importance of intergenerational contact and the potential and importance of family informal networks and intergenerational connection and collaborations to overcome loneliness in all ages and in all parts of society. So maybe one of the insights and lesson is the importance to go beyond older people, adult, elderly, in the context of loneliness, is to see it as a broader, holistic, crossing generation issue, which can interrelate all generations and view this issue through an intergenerational lens.
Thank you. Somebody asked.
Can I just add to that?
Oh, please go ahead.
I think that one of the I think Issi showed data that's very new data earlier, showing that we actually don't see a lot more loneliness now in the COVID-19 pandemic. And loneliness is not new. It's just the focus that we have on loneliness that's new. And I think that what's very exciting about this intervention is that it's not an intervention that creates social contacts. Because we usually think, like, let's fight loneliness by making friends, by connecting people. And this is actually an intervention that's looking within people. It's taking people into themselves to understand, or to deepen the understanding that isolation and being alone isn't necessarily lonely. And to tap into those resources of wisdom, like Professor Jeste has mentioned, and of resilience, and to fight loneliness that way. And that's why, and I think that this is very exciting in this intervention, looking at it in a different way, looking at loneliness in a different way, and trying to fight it in a different way, in a way that's very suitable for COVID-19 and for the times that we're dealing with right now.
Thank you. There's so many questions coming in. I'm trying to read it.
I have an interesting one. It was in the chat feature. There's a couple coming in. Do you see a difference between levels of loneliness in introverts and extroverts? Is there a difference?
Actually, not necessarily. I mean, you would expect that introverts will be more lonely than extroverts. However, loneliness is subjective, and it doesn't depend on how many friends you have. So an introvert may have 3 close friends and not feel lonely. An extrovert may have 30 friends and still feel lonely. So social isolation would be different in the two, but not necessarily loneliness. It's a question of how connected you feel to yourself or your close friends. That's what determines that.
Someone, which may be a good way to end this, this program. And then I also want to say that a lot of people have asked questions about following up, and we will have opportunities for that for future events. And we will be in touch with everyone on how they can contact us more about the study. But a participant just asked if it's possible to get a white paper or book or pamphlet that can make this approach available to more older adults. There's a great need that exceeds the number open for the study. So do either one of you want to comment on that? Anyone?
I mean, I can say that we'll need to wait till the study is done, because then it becomes evidence once we have the data and they are accepted for publication. But we'll be happy to talk about the study as it is going, but it's important to wait till we have definitive results, right?
Right.
Nonetheless, the strategies involved, I think there are things probably we have written that we can send out. Issi, you have, and Nicole, you may, and Daniel may have some other thoughts too.
Yes, I can only add to what Dilip said, that again, as scientists, we usually wait to see the outcomes, the result, to analyze We usually use more academic avenues. However, I think one of the nice things of this project that eventually we would like, or at least attempt to provide some more popular or broad publication that will be available both in English and in Hebrew to our audiences. So it will be accessible and available to the broad public and older people who are not necessarily scientists or read scientific literature. So that's definitely one of our goals.
Yeah,
Yes.
so Susan, one thing that the Center for Healthy Aging's been doing during the COVID-19 pandemic is sending out weekly videos to our community with tips about how to manage loneliness, or I did an exercise on how to increase resilience. So if you send out a link to our website, we do have a number of videos, short videos that we've created during the shutdown that can help people with some of these areas.
Wonderful. I will do that. I also just got a message from someone from a large independent living and assisted living resident called the V that said that they have some Holocaust survivors who are very interested in participating.
That's fantastic. We would love to connect with them.
So we'll be in touch.
Yes.
So I just want to say to the University of Haifa, Issi Doron, Michael Isaacson, to the UC School, Stein School of Aging, Dilip and Danielle, thank you so much for participating in this first panel. And I know that there'll be more, and we thank you for your collaboration very, very much, and are thrilled to be supporting it. Thank you.
Thank you so much for your
Thank
support,
you.
Susan. We appreciate it.